So guys, today we are going to discuss the diagnosis and the treatment section for bronchial asthma. In one of our previous videos, we have already discussed about its pathophysiology, but today let's dive into how to diagnose it and then how to manage it. So we all know that asthma, bronchial asthma comes under the umbrella of chronic obstructive pulmonary disorders, okay, that we call COPD. But we all know that in chronic obstructive pulmonary diseases, asthma is not the only thing. It's not the only disease. We have four diseases that comes under the umbrella of COPD: chronic bronchitis, chronic asthma, which is bronchial asthma, emphysema, and bronchiectasis. But we are not going to go into the details of all of those. We're just going to focus on the diagnosis of bronchial asthma. But before that, you have to understand what does it mean by chronic obstructive pulmonary disease. When we say chronic obstructive, what does it mean? So basically, the obstruction, when we talk about the word obstruction, it means difficulty of getting the air out of the lungs. Okay, it simply means that the difficulty in exhalation. Okay, you can breathe normally, but the problem is in exhalation. You cannot exhale it out. That is why the air is trapped inside the lungs. Okay, so we call it air trapping. That's what the actual problem is in the obstructive conditions. So airway obstruction, which is ultimately, of course, leading to the air trappage, is going to clinically manifest with changes in spirometry, right? So you all know that spirometry is a diagnostic test. It is a pulmonary function test, and let's say the most common pulmonary function test to diagnose any obstructive condition or diagnose any lung condition. Okay, so spirometry, when in spirometry, what do we do? What do we measure? We measure the amount of air, that is the volume of the air, and the speed or flow of the air that can be inhaled or exhaled. That's what we measure in spirometry. Okay, spirometry is a very simple technique, and it gives you a lot of information whether the condition is obstructive or restrictive. That's what it does, and it's the most simple technique. All right, so what do we measure? We measure the amount of air, which is the volume, and the speed of air that can be inhaled or exhaled. That's what we do in spirometry. But how does spirometry help in assessing the obstructive pattern? That's the main question. That's the next question. Okay, so before going into that, you have to understand a few terminologies, a few terms related to the lung function. So first of all, as you can see, tidal volume. What does it mean by tidal volume? It is the volume of air inhaled or exhaled in a normal breath. So normally at rest, when you breathe in and when you breathe out, that's what the tidal volume is. The normal amount of air that you breathe in and breathe out, that is tidal volume. Simple as that. Next is inspiratory reserve volume. What does it mean by inspiratory reserve volume? It is the maximum air that can be inhaled after a normal inhalation. So normally at rest, when you inhale like in a certain amount. You inhale certain amount. You do not inhale the whole of your capacity, right? You inhale a certain amount, a certain volume of air. But after inhaling that certain amount, you can forcefully inhale extra amount of air, extra volume of air. That extra space that we can inhale in, that's what we call inspiratory reserve volume. So the extra volume that we can inhale in after a normal inhalation, that's called inspiratory reserve volume. And as far as expiratory reserve volume is concerned, it is the same. It is the maximum air that can be exhaled after a normal exhalation. All right, because after in every exhalation you exhale out a certain amount of air, but when you exhale out certain amount of air, certain volume of air, you feel that there's something that you can do more if you try. Okay, if you force yourself, you can do more, you can exhale more. That's what expiratory reserve volume is. Okay, so that after normal exhalation, whatever the volume of air that you can forcefully expire out, that is called expiratory reserve volume. So these are the terms: tidal volume, inspiratory reserve volume, and expiratory reserve volume. Now you have to know what is vital capacity. Okay, vital capacity is basically the total exhalation after the maximum inhalation. It's simple, right? The total exhalation after the maximum inhalation means after the max forceful inhalation. Okay, the amount of air you exhale out, you breathe out, that is vital capacity. That brings us to another terminology, which is forced vital capacity. What does it mean? The amount or the volume of air which you forcefully exhale out after a full inhalation. All right, so remember, you have to inhale fully. You have to inhale fully, and the amount of air that you can forcefully, not normally, forcefully exhale out after a full inhalation, that is forced vital capacity. And forced vital capacity gives us forced expiratory volume during 1 second. It simply means that the volume of air that can be exhaled in the first second of the FVC maneuver, means forced vital capacity maneuver. You ask the patient to fully inhale, right? And then you ask him to exhale forcefully, not normally, forcefully. While he is doing that forceful exhalation, you turn on the clock stopwatch, okay, and you measure the time duration. The amount of air that he exhales, or the person exhales during 1 second of that FVC maneuver, that is called forced vital capacity. All right, guys. So you all got the understanding of the terminologies that are helpful in diagnosing any sort of lung condition, especially when you're doing spirometry, because these are the terminologies that spirometry or pulmonary, the most common pulmonary function test performs on. It is based on. All right. So now let's come to how to diagnose obstructive pattern, how to diagnose that the lung condition that we're talking about is obstructive or restrictive. All right. So how do you do it? Now, when you do spirometry, okay, in obstructive condition or restrictive condition, whatever it is, when you do spirometry, okay, the FVC will be dropped, okay, the forced vital capacity will be dropped, okay, and forced expiratory volume during 1 second will be dropped even more. So forced vital capacity is dropped, but the forced expiratory volume is dropped humongously. All right. Now, what do? You divide FEV1, which is forced expiratory volume during 1 second, by forced vital capacity. When you divide these two values, if the answer comes to be less than 75% after doing these simple mathematical calculations, if it turns out to be less than 75%, it means that the condition was obstructive. The condition that we were talking about was obstructive and not restrictive. So now we have got the idea that the condition is obstructive, but we do not know what actually it is, because in obstructive condition, as we discussed earlier, that we have got 4 diseases. Okay. So now we have just gotten the idea that it is obstructive. Now, what do? That you give the patient SABA. SABA is short-acting beta-2 agonist. Okay, you all know that beta agonist drugs are those drugs which cause bronchoconstriction. So now you give SABA to the patient after you get this value. Okay, this is short-acting and it will immediately produce bronchoconstriction in the patient. After giving SABA, you perform pulmonary function test or spirometry again. Okay, now after performing PFT, if the result of FEV1, forced expiratory volume, during 1 second, it turns out to be more than 12% or equal to 12% after giving SABA, that helps us to say that the condition is asthma. The condition is asthma. But if it is less than 12%, okay, then we say then the condition is simply bronchitis. Okay, bronchitis. So now you get to know, you have gotten the idea that how do we differentiate bronchitis, which is an obstructive pattern, from asthma, which is also an obstructive pattern. Okay, so now this test you perform after the patient comes to you with the symptoms already. But if the patient comes to you asymptomatic without any symptoms, then what do? How do you perform spirometry? Because to perform spirometry and for the spirometry to give accurate results, you have the symptoms. You have to have the symptoms. The patient has to have the symptoms. But if the patient is asymptomatic, you perform an other test that is called methacholine challenge test. Methacholine challenge test. Okay, so what is methacholine challenge test? Methacholine is a potent bronchoconstrictor. Okay, it causes bronchoconstriction and it comes in an aerosol form, spray or aerosol form. You ask the patient to inhale that methacholine. When the patient inhales it, it produces immediate bronchoconstriction in that patient. Okay, it produces bronchoconstriction. Now the bronchoconstriction has been induced by methacholine and the symptoms will start to appear. Now, once the patient becomes symptomatic, you perform PFT or spirometry again. Now, after performing PFT or spirometry, if the FEV1, which is forced expiratory volume, during 1 second, it drops 20% than the original value. Right? What does it mean by 20% than the original value? When the patient came to you without any symptom, so before performing methacholine test on this individual, you did his normal lung function test. You did PFTs, you did perform spirometry and the results were normal. Okay, but after methacholine test, if FEV1 turns out to be drops more than 20%, if it dropped 20% or more, then you say that the patient is asthmatic. So now you have gotten the idea that if patient comes to you with symptoms, how do you diagnose asthma? And if patient comes without symptoms, how do you diagnose asthma? So this was a simple diagnostic technique using PFT or spirometry. How do you differentiate obstructive conditions among themselves? And once you get to know that this condition is obstructive, how do you diagnose asthma? So this was pretty much it as far as diagnosing asthma was concerned. PFTs and spirometry was the main thing that needed to be understood. There's one more thing, and that is ABGs, arterial blood gas. How do we, what do we find in arterial blood gas in asthmatic individuals? So we know that asthma has exacerbations. It's not that individual when he's asthmatic, he's symptomatic all the times. He's not symptomatic all the times. He has exacerbations. So in early exacerbation, the patient is still in a state of compensation. What do I mean when I say in a state of compensation? So you all know that asthma is an obstructive condition and the problem is related with air trapping, right? When the problem is related with air trapping, it means that the patient cannot get rid of carbon dioxide. That's when his compensatory mechanisms come into play. And what are the compensatory mechanisms? Of course, to get rid of carbon dioxide. And how do we get rid of carbon dioxide? Through hyperventilation. So in early exacerbation, the asthmatic individual will of course hyperventilate, and he somehow will succeed in his efforts, right? And that's why we call it compensation, because if he's not succeeding in his efforts, that is decompensation. So when he succeeds in his efforts to compensate, it means he get rid of carbon dioxide. When he gets rid of carbon dioxide, it simply means that the carbon dioxide concentration in his blood drops down. When carbon dioxide in his blood drops down, it means carbonic acid is not going to be produced. Okay, because we know that carbon dioxide reacts with water and produce carbonic acid, which gives acidic content to the blood, which adds acidity to the blood, right? So if H2CO3, which is carbonic acid, is going to produce in a lesser amount or is not going to be produced, then we say that the patient is going into alkalosis, and this type of alkalosis would be respiratory alkalosis. So that's when you can see in early exacerbations. But in late exacerbation, when the patient is in a state of impending respiratory failure, he cannot compensate anymore. Okay, chronically, when the patient he has let's say the disease for long periods of time, okay, and he is unattended for the most of his life with this disease, okay, then he ultimately goes towards decompensation. And in a decompensation, you will not see alkalosis, you will see acidosis, and that acidosis will be respiratory acidosis. So that's what you are going to see in arterial blood in early exacerbations and in late exacerbations. So this was pretty much about diagnosing bronchial asthma. For the treatment section, we will go to the next video, because the video is getting too long, and that was till now how to diagnose bronchial asthma and how to differentiate the obstructive conditions within themselves.